Hi, everyone. My name's Cameron Casson. I'm one of the general surgery residents at Washington University in St. Louis. Thanks so much to SAGES for having me here today to present our work. Nothing relevant to disclose to today's presentation. Shared decision-making, or SDM, is the collaborative process between a physician, a patient, and their family to really weigh the risks and benefits of every treatment option available for a patient, including no intervention at all, and how these options fit into an individual's values and preferences. This really emphasis on values and preferences is what separates this from the regular informed consent process. Often decisional aids are used to guide these conversations in practice. We thought that the older ventral hernia population was the ideal group to use shared decision-making in. Ventral hernias are often an elective procedure, allows time for longitudinal discussions with patients and their families. There's also multiple decision points that happen during these talks. Should we do surgery at all? If we do, when do we do it? And how do we do it? These are all, questions we ask in the context of a patient's individual risk factors. For the older patients, this can often be unique things like frailty and cognitive impairment. So our group was interested in looking at shared decision-making in this population, and particularly how it plays in with patients' expectations, and ultimately its potential influence on decisional regret after treatment. So we developed a novel shared decision-making tool that we implemented in our specialty hernia clinic. All patients 60 years or greater who were coming in with a ventral hernia were eligible to participate. If they agreed, they were randomized into either the control group, which just underwent their standard consultation with the surgeon, or the experimental group, which had their visit guided by our new SDM tool. These patients had various surveys that they completed along the way, both at their initial consultation, as well as a member of our study team called them 3 to 6 months after they had made their decision to follow up with a few additional surveys. So this was the first one that our patients saw when they walked in the door to our clinic, just really gathering what their expectations were and what preconceived notions that they were bringing into their appointment with their surgeon. We also asked them the control preference scale at their initial visit. This is a validated tool that describes how patients like to make decisions about healthcare. It's on a spectrum with kind of one end being the more patient autonomy. I prefer to make the final selection about my care, all the way down to kind of on the last question, the last option there is the more paternalistic model where I want my doctor to choose my care. And then we asked them actually the same question at that follow-up call 3 to 6 months later to kind of reflect on how their decisions were actually made, to see if how the congruence between the reality of their decision and their initial preference was. At that follow-up call, we also asked them the decision regret scale, another validated tool that's used to measure remorse in patients after a healthcare decision. This raw score is then converted into a linear scale from 0 to 100, with higher scores indicating more regret. So we had 72 patients that enrolled and completed their final follow-up. 36 patients were randomized to each arm. There were no differences in any of the demographics we looked at between the two groups. Looking at their expectations, the vast majority, thankfully, did know why they were coming to the hernia clinic, but there were a few that weren't sure why they were there to see the surgeon. Interestingly, a little less than half of our patients noted on their survey that the referring doctor told them that they'd be having surgery. I thought this was an interesting point. When another medical provider is helping shaping patients' expectations, I think that leads to an interesting dilemma for us. Looking at it, most patients, presenting to our clinic did expect and want their hernia to be repaired. So this is how kind of our cohort broke down. About half of each of the study groups here had surgical repair of their hernia. Of those who did not undergo surgery, some chose observation because they did not want to go surgical repair at that time. And there were some individuals who, after discussion with their provider, wanted to do some prehabilitation in order to optimize their hernia repair, things like losing weight, optimizing comorbidities. So now that this is kind of how the group shaked out, we wanted to look how their decision regret scores kind of differed between the groups. For our ventral hernia population, again, these numbers are on a scale from 0 to 100 with higher scales indicating more decision regret. We saw that there wasn't a difference in decision regret scores in patients who had their visit guided by the shared decision-making aid. When we looked at which treatment people chose, however, we found that those patients who had surgical repair had significantly less decision regret scores than those who did not have surgery. So we wanted to dive in a little bit more to that and look just specifically at those patients who didn't have surgery. I don't think it's too surprising, but those patients who had to undergo medical optimization had higher decision regret scores than those who chose observation. However, when you're looking at it a little closer, when we broke it down into the control group and the experimental group, the control group, this difference was not significant. Perhaps that could be due to patients feeling less responsible for choosing to not have surgery. So just an interesting finding there. We also found that those patients who reported wanting or expecting surgery but ultimately did not undergo repair had higher decision regret scores. However, on the inverse was not necessarily true. Those patients who did go surgery, we didn't really see a difference between those who initially reported not wanting or wanting surgery at their initial expectation survey. Additionally, though these numbers were small, there wasn't a higher decision regret in patients who had a postoperative complication. So lastly, we were looking at our controlled preference scale. So again, this was asking people how they prefer to make decisions pre-treatment, which is noted by the maroon bars here. And then we asked them again kind of how they made their decision, which is represented by the pink bars. The solid lines are our control group who did not have their visit guided by the aid, and then the striped lines are our experimental group. And you can see here that most patients actually preferred and made decisions based off what they would recognize as a shared decision with their physician. When we looked back at that congruence, so the reality that how the decision was made and their preference stated initially, we didn't see any significant difference with the use of the aid or not. So in conclusion, in our specialized hernia center, the use of a decision aid did not lower decisional regret in our older ventral hernia patients. However, patient expectations prior to initial surgical consultation were associated with decisional regret, particularly in patients who did not undergo surgical repair. And most patients preferred to share decision-making responsibilities with their physician. For us, this really emphasized the need for upfront education and realistic expectation setting with our patients, and the need for longitudinal programs to really help patients reach their individual treatment goals. I do think it's important to note a limitation that this survey and the study was conducted at a specialized hernia center. All the physicians involved are fellowship-trained abdominal wall surgeons who have these nuanced discussions kind of day in and day out. So I'm not sure if we can generalize our data to kind of all clinic settings to say that a decision aid may or may not affect decisional regret in these complex patients. Thank you so much, and I'd be happy to take any questions.